So what is the process of getting a kidney transplant? This is a simplified version. You're going to talk to your nephrologist about transplant. You're going to determine if it's right for you. You're going to be referred to the transplant center. And after initial screening, they're going to call you for an evaluation. You'll see everybody on the team. You get the testing, everything is fine. You will be placed on the transplant waiting list, and then you'll get a transplant. So obviously, it's not as easy as that. This is a very simplified version. As you can see from this complex rail map, the process involves multiple parties and is very complex. Luckily, as I'm going to show you at the end, we will be able to discuss most of these points so you can feel more comfortable in your transplant journey. So who will be in your transplant team? Obviously, you as a patient, you are the most important part of your transplant team. Your family members who will help you throughout the process. The transplant surgeon, which is the physician, will actually place a healthy kidney on you. The transplant nephrologist, which will be in my case, which will usually help you determine the evaluation and the pre-transplant process, and will take care of you of the post-transplant process, including complications. You're going to have a transplant coordinator that's going to be your navigator throughout the process and your point of contact with the transplant team. You're going to have a transplant pharmacist, which is dedicated to make sure that your medications are appropriate for you. At the beginning, for example, in our center, our transplant pharmacists help manage most of the other extrarenal complications or manifestations. So if you have diabetes or other issues, we tend to work with you, particularly those first 3 to 4 weeks, because you know that you are staying local with us. You're going to also have a social worker that's going to help you throughout the process, not only emotionally, but might help you find lodging with the logistics and help in that area. You're going to have a dedicated transplant dietitian and a financial coordinator. So now that you're interested, you're going to get called. What are you going to expect in the transplant evaluation? We're going to make sure that you have a history of physical exam. You're going to get labs on imaging studies and immunologic investigations. Instead of the history of physical exam, we're going to try to determine the cause of renal failure in this room. Obviously, most of you are ADPKD. We're going to make sure or ask you about your history of infections, if you had a prior transplant or not. We're going to determine your cardiovascular risk, history of malignancies, any GI, respiratory or blood issues, pregnancies, and ultimately, some of the insurance will require that you undergo a dental evaluation before placed in the waiting list. So what lab and imaging studies can you expect? So we're going to screen for viruses. We're going to check your liver tests. We're going to check typical labs like the calcium and phosphorus. We're going to make sure that there's no infection with a urine culture. The basics will include an electrocardiogram. Ultimately, depending on your risk, age, and comorbidities, you might warrant a heart sonogram or an echocardiogram and a stress test just to make sure that it's safe for you to undergo the surgery without cardiac complications. Chest X-ray, abdominal imaging. This usually repeats every 3 years or so. The typical is the non-contrast CAT scan. And ultimately, we need to make sure that you have the age-appropriate cancer screening, as you can see. In terms of the immunological testing, we're going to check for your blood group and your human leukocyte antigen typing. Ultimately, it's more important the blood group compatibility than the HLA typing. We're going to screen for antibodies or even autoreactive antibodies. And we're going to have a cross-match in which we usually place your blood with the recipient's donor with the recipient blood to make sure that they don't attack each other and that the transplant is compatible. So moving along in the evaluation, thus the pre-transplant evaluation is different in ADPKD patients. For the most part, no. It's largely the same. The only caveat or difference is screening for intracranial aneurysms with MRI. We have seen that there's a higher prevalence of brain aneurysms in ADPKD patients. The main risk factor is that if you have yourself as an ADPKD patient, if you have a personal or a family history of intracranial aneurysm, you're going to be at slightly higher risk. The general population usually has about 2 to 3% of intracranial aneurysms. On patients who have ADPKD, that prevalence can be as high as 12%, particularly this number in patients who have that risk factor of a personal or a family history of intracranial aneurysm. The guidelines are not super clear on the surveillance, but we usually recommend if there's an asymptomatic known aneurysm for you to get an MRI once a year, And in those patients who have no MRI, we tend to recommend for them to be repeated every 5 years. So now you have undergone the evaluation, the testing, and you're placed on the transplant list. So let's talk about more about the transplant listing and waiting time. If you're a suitable candidate, you will be placed on the kidney transplant waiting list. Waiting time will vary depending on your blood type, antibody matching, time with kidney failure, and a few other factors that we will discuss in a couple of slides later. At this time, once you're listed, potential living donors can be evaluated. I know that some of you might have donors down the pipeline, but for example, in our center, we don't tend to do the full living donor evaluation until you guys are officially listed. The reason being is that we don't want to overuse resources, and some listing for patients take longer, and we have to keep up periodical evaluations every year. So if you are listed in the deceased donor waiting list, you will be required to come back once a year and realize that some of that testing will have to be repeated as well. For example, if you're older than 50 and have cardiac risk factors, we want to repeat the heart sonogram every year, but physically we want to see you. So what can you do in this time once you're on the waiting list? Our recommendation for you is to try to stay healthy as possible. You're gonna take your medications as prescribed. You're gonna try to exercise as much as possible. You're gonna follow your healthy diet. You're gonna keep up with your medical appointment and visits and be compliant with dialysis. So what can you expect if you're placed on the waiting list? In this Sankey diagram, it shows the outcomes in the 3 years following kidney transplant wait list. On the left here, we assume that all the patients are placed on the wait list and are started on dialysis. By year 1, 69% of the patients still remain on dialysis. 2% of their patients were delisted or removed from the list for complications, personal or comorbidities, but they're still on dialysis. About 26% got a transplant from deceased donor, and living donor, and 3% died. By year 2, 6% of the patients on the waiting list have died. About 38% of them have received a transplant, 6 were delisted, and about 50% remain on dialysis. As you can see, more patients are transplanted as time goes by, but there's still more mortality. So the longer you wait on the longer you are on the waiting list, the more chances you have of either being delisted or dying. Emphasizing the importance of preemptive transplantation, preemptive referral, and living donation. So how organs are matched? What I'm going to discuss here is the brief overview and applies for all different types of organs, whether it's like a liver, transplant, heart, or lung. So the first step, before an organ is allocated, all transplant candidates on the waiting list that are incompatible with the donor because of blood type, height, weight, and other medical factors are automatically screened out. Then the unit, which is the unit computer system, will determine the order that the candidates will receive the offers. And that kidney allocation factors we're going to discuss on the next slide. So in addition, after everybody that's not compatible is screened out, we're going to take a look about the geography. So organ transplants, we know that are more successful when they have less time out of the donor's body. So geography does plays a part, and we try to allocate organs accordingly. And also the right size organ. This is more important in other transplant, like for example, lung transplant, that you need that perfect size. But it's applicable in kidney, because if you have a small kidney or a pediatric kidney, we try to allocate it to young healthy patients as well. So what factors are specific in kidney allocation? So in kidney allocation, we take into account the waiting time, meaning how long have you been listed or how long you have been on dialysis. We talked about the donor and recipient immune system compatibility. In addition to blood typing, we also take a look at what we call the calculated panel of reactive antibody. This is a score that we use as a surrogate marker for sensitization. And I'll try to take some time to explain this. So patients who have had prior transplant, multiple blood transfusion, multiple pregnancies, or autoimmune conditions can develop what we call antibodies against their pool of donors. That's going to make them harder to get a transplant or to get a successful match, And that's why we tend to give more points to these patients. Conversely, if you have a low CPRA score, we know that it's going to be easier for you to get a transplant. We also give priority to former living donors. So for example, in the cases that I've listed, former living donors, the waiting time is usually weeks to months versus having to wait years for deceased donor. So we try to protect former living donors. And as I mentioned, the distance from the donor hospital is going to be a big consideration. The survival benefit is going to be an important consideration in organ allocation, and the pediatric status. In terms of the pediatric status, as I mentioned, we try to give priority to those younger patients. As a matter of a brief review, and I'm sure that most of you are familiar, so blood typing. So donors with blood type A can donate to recipients with blood type A and B. Same with donors with blood type B can donate to B and AB. Donors with AB can donate to recipients with AB. And the universal donor or blood type O can donate to all the blood types. Conversely, as you can see here, recipients with blood type O can only receive kidney from blood type O. This explains why this blood type have to wait usually longer. In our region, it's about 4 years of waiting time for a deceased donor for blood type O, and up to 6. Recipient with A can donate to A and O, B to B and O, and universal recipient is AB, can donate from any of the other blood types. So now we're going to talk briefly more about those, like I mentioned here, the survival benefit score, so you can understand. So let's talk further about the Kidney Donor Profile Index, or KDPI. So the KDPI combines a variety of donor factors into a single number that summarizes the likelihood of graft failure after the deceased donor transplant. It takes into account your age, height, weight, ethnicity, history of hypertension, diabetes, the cause of that donor death, and the serum creatinine, and the HSV status, or the hepatitis C virus status, and if he was a donor from deceased cardiac death or not. So we use this to allocate kidneys, and it's like a surrogate marker to see how long that kidney is going to last. As an example, you can see here that living donors, for example, their half-life was about 12.5 years, and then as the higher the score the KDPI gets, the lower the half-life. This is important in particular cases in which, for example, either you have a highly sensitized patient that cannot get much offers, or if you have an older individual that cannot sit on the waiting list for 2 or 3 years because he might get delisted, this may be the best option for those patients. On the other hand, we have what we call the estimated post-transplant survival score, or the EPTS score. Same as the KDPI, is a score that can range from 0 to 100. And as a difference, the KDPI was more for the donor. This is more for the recipient. So it's a marker of how long that recipient will survive after transplant. The lower the number, the better. It takes into account your age or date of birth, if you have started dialysis or not, if you have diabetes, and if you had prior transplant. This is important usually for younger patients. So if you have a low EPTS score, particularly less than 20, you will get priority and receive offers for kidneys with donor with low KDPI. So we try to do what's best for those young patients in which we foresee that they're going to live longer. On the other hand, if your EPTS score is higher than 20, we don't take that into account. So now that you're listed in a center, what options can you have? So let's briefly talk about multiple listing. So what is multiple listing? Multiple listing is when you register at 2 or more transplant hospitals. Candidate listed at hospital closest to the donor hospital, we get more matching priority. So when I mentioned before about distance, this is something that you can take into consideration. Why? Because it can shorten the average of waiting times of kidney transplant by several months. It's important to note that this does not mean that every person who does so will have a shorter waiting time, and you have to consider the economic burden and the social support at a different site. So it's going to be costly for you to travel to a different state, whether it's by plane or car. You need to think about who's going to take care of you in that center if you have to go to another state, thinking that you might have to stay locally for at least 4 weeks. And if there's more complications, you might have to stay longer. So this might not be for everybody, but it's a potential option in which you can do to try to get transplanted sooner. So if you're considering multiple listing or even just listing as a center, can you check how well your center is doing? Yes. So the survival rates among kidney transplant recipient in the United States, transplant centers can be found online at the Scientific Registry of Transplant Recipients website, or the SRTR. I use as an example the centers here locally. So this is my center. For example, you can see how many transplant they do. With obviously the more the better. It means that they're more experienced. You can see how quickly you can get a deceased donor transplant and your 1 year survival. Take into account that this graph here, take into account that this graph here, we start with a 90% survival. So for example, our center has a 94% survival on the first year. And we can definitely get you transplanted quicker when you have better volumes. Not trying to sell myself, but it's important that you empower yourself and and try to choose the best center for you in the event that you do have an option locally. So now that you got transplanted, so you got on the waiting list and you got a transplant, what are you going to expect after? So the average inpatient stay is about 4 to 7 days. After that, you're going to be discharged and regularly follow our clinic. So for example, our algorithm on patient follow-up is that we're going to see you twice a week for the first month with labs twice a week. Then after that, if everything goes well, we're going to start spacing out at twice a month for the first 3 months, then monthly until 6 months, and then every 2 or 3 months until 1 year. After that, if you have a local nephrologist, we just refer you back and we can see you once a year for immunosuppression surveillance and our complications. During that first month, I expect to be in some form of discomfort, not pain, but discomfort. And we usually ask you to wait at least for 6 weeks because of any major heavy activity for the avoidance of complications like hernia from the surgery. So realize that during this time, you will have to keep up with your PCP and specialists as usual. You're gonna have to maintain a healthy lifestyle with diet and exercise, and you will avoid missing medications at all costs unless instructed because of the risk of rejection. This is particularly true for young patients, unfortunately, in which after they transplant, they feel better and they start getting loose or lax, miss medications, and then they lose the organ. So very, very important. Now that you got a transplant, how long it will last? So let's talk briefly about the long-term kidney transplant graft survival. This is number from whether 1995 to 2017, and it takes a look at all the transplants in the States. Fortunately, we have been doing better. On the left, the most recent cohort of deceased donor kidney transplants showed us that the average graft survival was close to 12 years. And then on the right here, you have the average graft survival of live donors, which tends to last slightly more than 19 years. So as you can see, they're both great, but the living donors tend to slightly last longer. On that note, we can briefly talk about the advantages to recipients are receiving living versus deceased donor kidneys. So one of the advantages is, as mentioned before, there's no waiting time. Once you have a living donor approved, it will take you probably 1 to 2 months to get it scheduled. On the other hand, if you have to wait for a deceased donor kidney, depending on your region and your blood type, you might have to wait something from 2 to up to 6 years. So those living kidney donors tend to last longer. So the donors are healthier, there's shorter ischemic time, and less overall damage to the kidney, including less rate of rejection and less delayed graft function, which is a topic that I'm going to discuss in the next slide. And as it might make sense or common sense, scheduled surgeries tends to have fewer complications than emergent surgery. And there's also a benefit for the patient, or patients tend to live longer. As we can see, there is a better survival at 5 years for patients with living donor, which is about 91%, deceased donor, 84%, and about 70% for high KDPI kidneys. So what's delayed graft function? Delayed graft function is defined as an acute kidney injury within 7 days after kidney transplant that requires dialysis. This is seen in about 20 to 30% of kidney transplant from deceased donors. It is associated, unfortunately, with higher rejection rates and worse short and long-term outcomes. The major risk factors for this is the ischemia or reperfusion injury. This happens when we procure a kidney, we put it on ice, and then we have to flush it with blood. So that release of cytokines and enzymes will harm the kidney. The source of the donated kidney will take into account. So living donors nearly don't have any DGF at all. And then from deceased donor, if you receive a kidney from a cardiac death, you will be at higher risk of developing DGF than somebody who was brain dead. The quality of the donated kidney takes into account DGF and the clinical conditions of the recipient. For example, if you have an older diabetic patient with vessel disease, your risk of DGF is going to be higher than somebody young with ADPKD. So lastly, I would like to briefly mention about patient advocacy in kidney transplant. So patient advocacy is based on the belief that patients have the right to select values they deem necessary to sustain their lives, the right to decide which course of action will be best achieve the chosen values, and the right to express their values without coercion by others. I see patient advocacy in a multi-level, from the individual to the institutional or even the legislative level. As an individual, what can you do? Either you or your loved one are undergoing this situation of kidney failure. You're going to try to educate yourself at best and try to advocate for the loved one or yourself. As an institutional level, we need to include patients in the decision that we make throughout the process. We need to include patients in the planification of the transplant surgery, in the planification of medication. As a legislative level, we need to do better as a kidney community and try to advocate for our patients. The typical example is, as I yesterday was talking about, the Living Donor Protection Act, which is something that we're trying to advocate for in a legislative level that would help more living donors come forward. So like as I mentioned, what can you do? I want you to come prepared to your visit and try to read as much as possible. There's a bunch of good resources, information out there. You have the PKD Foundation, we have the National Kidney Foundation, and multiple other trusted institutions that are here to help you and give you clear-cut information that you can understand. And I want you to, once you're in your center and in your visit, to ask direct questions and set clear expectations to your team so you can align your goals with the transplant. And that will be it. This is my contact information. You'll have any questions? Thank you. Thank you. Any questions from the patients?
The highest GFR they will do a transplant if you have one kidney.
Okay,
Is
so
it still 15 to qualify for a transplant if you have one kidney?
we tend to see either one or both, like as a single unit. And for you to be able to be listed based on the current regulation, your GFR has to be 20 or lower.
20 or lower.
20 or lower, yes. So once you are stage 4, meaning less than 30, I mentioned that you should start the discussion, or your kidney doctor should start that discussion about what are your options and what are you gonna do. Once you're in the low 20s, you should have already been referred to the center for the evaluation. We can start usually before the 20s, but we won't be able to put you on the list until we have a single lab. We just need one showing that your GFR is 20 or lower.
Well, I've been on the list that my GFR dropped to 18 6 years ago after I had kidney cancer. So I'm on the list, but UCLA, they won't touch me till I'm below 15.
They're smart. That's the right thing to do. Let me explain. So as you see, the transplant don't last for your lifetime, and there's complications with it. So there's a sweet spot. We want to transplant you before you are dialysis, but we want to squeeze your own kidneys as much as possible. So that one shot that you probably have, you take it into account. So most of the studies, again, argue that you need to be transplanted ideally before you start dialysis, but at the same time, we have to be smart and try to use your own kidneys for as much as possible. So if you're asymptomatic and doing well, they're probably doing the right thing. And I think it won't be moral to do any transplant with that high GFR, particularly if you're feeling well.
Okay, thank you.
So you're in a good center then. I think the gentleman here has a question.
Said you're a transplant specialist down in New Orleans at Tulane.
No, I used to, yeah.
You used to.
Yes.
We live near there and we're looking for somebody with experience with the polycystic kidney disease. And I was wondering if you knew that if Tulane did have a nephrologist there that specialized in that.
So we do have one that has, but it's a general nephrologist that specializes in PKD.
There is
But,
one.
where do you live, particularly in
We
Louisiana?
live just north of Hammond, about 60 miles.
So
I
your
mean,
best,
north of New Orleans, I'm sorry.
so your best options are probably either Oxnard and Tulane. Obviously, I work at both. I am fond of both. I don't want to be biased, so I encourage you to enter the SRTR that I showed you. The link is there, and then you put your if you put your PO address, it will show you all the centers. It might include Willis Knighton, which is higher up.
Okay.
And then you say like, hey, which center is doing more transplant, which has better survival, and which can get me transplanted quicker.
Okay.
But you do have the option to check both,
Okay. Thank you so much.
right?
Any other questions? No.
Okay, so I'm 70. I'm still, my creatinine level is still good, within normal range, it's high. And they're telling me that I should need a transplant at 80. Do they even do that?
So so there's no age limit for transplant. Obviously, the older you are, the more risky and the more complications. Personally, the oldest patient that I've transplanted, it was actually a PKD patient. She was 82 years old and she did great.
There you go.
Again, I'm not making any false promises. It's individualized, but overall, as a transplant community, we know that, as I showed in one of the graphs, I don't know if you made it on time, but across the spectrum, even on the older patients, there's a clear benefit. So it's individualized. If your overall is going to be safe for you to be okay with the surgery and to tolerate immunosuppression under potential complications, you can be 80 and you can still get transplanted.
But I'm O positive. That's not good, apparently.
You should get listed as soon as possible. So once that GFR is at 20, you should be on the list so you can start accumulating time. If they're able to place you on the list before dialysis and you can sit on it for 3 or 4 years before needing any renal replacement therapy, that increases your chances of successfully getting a transplant.
My question is, we actually live here and in San Antonio,
Okay.
and San Antonio does the most, or is one of the highest transplant numbers in the country, but they're not necessarily PKD transplants. Does that make sense?
Yes.
How do I find out which has a higher success rate at PKD transplants, Anschutz or San Antonio?
I would just look at the overall success rates. Like I mentioned in the beginning, patients, we tend to prefer PKD patients because they do better. So it's going to be easier than any other conditions like diabetes, high blood pressure, autoimmune disease. So I would just try to look at the overall success rates. I think, where are you listed in San Antonio, in UT? Okay. Again, I'm biased. I'm going to say that we are the best center, but I will encourage you to look at the SRTR data. And if economically feasible, I will get listed at both. And then we probably will, what blood type are you? So you're going to get listed or transplanted super quick, and we'll probably get you transplanted quicker. So it's up to you ultimately, but based on your blood type, you'll probably get transplanted within 1 to 2 years of active listing. And again, we are the best center, but it's because I work there, but we do really good. So all jokes aside, I encourage you to try to compare both centers in the SRTR. And have you been evaluated at both centers or no? So you'll get a very good feel to, so I encourage you to keep your open mind and try to go for both. No? if it's frowned upon, then you're in the wrong center. As a healthcare providers, what we want is the best for the patient. Whether it's here, Louisiana or San Antonio, I don't care. As long as you get a transplant and do better, that should be the north. So we should encourage you to do what's best for you, even if it's getting transplanted at another center. So if you come to see me at multiple listing and I know that the other center gets you transplanted quicker, I'll say like, hey, you can get listed here, but chances are that you will get transplanted quicker at the other center. So we usually don't get paid for many cases. We have like I said, so I don't, it's not any personal change if I get transplanted or not. So I just want you to do well, and that should be the most important thing. And I think that
I was just curious about the need for the dental exam before getting on the list.
it's based on, it's insurance mainly.
Okay.
I tend to, so just by speaking with you, at least in the era of non-mask, I can see if you have any dental issues. The main reason is that some patients require invasive procedures like a tooth extraction or a root canal, and the medications that we use for immunosuppression sometimes impair wound healing. In particular, like there's a medication called mycophenolate, which is very important. And if you have a surgery, you might not heal as quickly, particularly as if it's invasive. But it's insurance dependent, and not all insurance required it. And again, if I talk to you and I don't think anything crazy out of the usual, I won't even request for it.
Thank you.
And I think the gentleman here had another question. No,
If the numbers are controlled and they get back to normal numbers, just do diet, you're still not allowed to donate?
no, diabetes is an absolute exclusion. Even if you are pre-diabetic or have what we call glucose intolerance, it's very hard for you to be considered as a donor. Diabetes is the main cause of kidney failure. And in 8 to 10 years of poorly controlled diabetes, you'll be on dialysis. And even those who have great control ultimately might be at risk of developing kidney failure, particularly from the protein spillage or proteinuria. So diabetics is an absolute exclusion, even if they are well controlled.
So if they hit pre-diabetic, but then can reverse from there, would they still be able to donate?
Yes, they might be able to be considered if everything else is great. If they're not obese, if their cholesterol is great, if they don't have any what we call metabolic syndrome complications like cholesterol, obesity, blood pressure. So if everything is great, they might still be able to consider donation, as long as they're able to prove and are ready to keep up with that good care the rest of their lives.
One of our sons has a marker for the recessive PKD.
Mhm.
And would they consider someone who carries recessive in a transplant?
So it depends. So that will be genetic testing. So depending on the genetic testing and the risk, you might be considered or not. So if we know that you have the same genetic, so let me backtrack. So first we need to make sure that so you're trying to say that one of your family members is trying to donate to other?
Well, right. So he's AD PKD and they tested genetically our 2 other children. And one has nothing and one has some genetic marker for the recessive.
So that will be excluded from donation.
Okay, he would be.
If you have the same genetic mutation,
Got it.
even if it's perfect, but it will be at higher risk of the future of developing it.
Yeah, that's what we figured. Okay, thank you.
Any other questions? Yes, ma'am.
I'll wait for the microphone. Any exclusions related to the liver cysts? If you have both cysts on the liver and the kidney? Any complications
So no,
for transplant?
there's a small subset of patients who do have the polycystic liver disease as well. In those cases, it depends. If your liver is sick enough, then you will benefit from a combined or a simultaneous liver and kidney. We tend to do that.
Okay.
So in those cases, the liver team will be the main driver of captain of the ship of the transplant because it's a bigger surgery. So in the event that your liver is affected with polycystic kidney disease, then your option will be to undergo simultaneous liver and kidney, which is very doable, feasible, and we tend to do that a lot. I try to steer away from the liver transplant. I know some about, I see most of the patients, but that's not my area of expertise. So There's what we call particular set criteria for you to qualify for it. So if your liver is sick enough and then your kidneys are failing, which most of you probably are in the same boat. For example, if your GFR is less than 60 for 3 months and at the time of listing less than 20, then you will benefit from a combined liver kidney. So there's certain numbers that we tend to use. But yes, it's very doable and you would benefit from it. And we know that patients do very well.